tachycardia.
Is this SVT?
Yeah, so you can say
WPW.
you can't say this is not WPW. WPW is usually narrow complex tachycardia.
Broad QR interval.
So if you look at this ECG, uh, just go simply. Look at the rate. Is it fast or is it slow?
Fast.
Fast.
Fast. Is it regular? Is it irregular?
Regular.
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 Yeah. Is it broad complex or narrow complex?
Broad
Broad
complex.
Yeah. What are the axes?
right axis
So at least
deviation.
if you say this to the cardiologist who is away from you, like, look, I've got a patient who's got fast heart rate, which is a regular rhythm, broad complex tachycardia. So broad complex tachycardia should always alarm you. This patient has taken an overdose of tricyclic antidepressant. Okay,
Oh,
Oh.
so what is the pathognomic feature of tricyclic antidepressant?
QT long.
No,
QT.
that's not pathognomic feature. You can have a prolonged QT. So I was expecting you to say this to me as well. You have to comment on PQRS,
Yes.
QT. Sorry?
Tall. Tall T due to
Torses
hypokalemia.
torses the point.
No. Pathognomic feature means you only see that feature in that condition and you don't see in anyone else. So if you remember, Dr. Sakib taught you about lead AVR. You remember that?
Yes,
Yeah.
upright
Yeah. So
deflection.
lead,
Upright deflection in AVR.
good. So, lead AVR is like a 12th man of the football team
ECG.
or a
Yes.
cricket team. Then most of the time people ignore it. So you should not normally have a positive deflection at lead AVR. If you look at the normal ECG, yeah, if you look at the normal ECG, AVR, is it up or down?
Down.
Down.
It is down, isn't it? And as Dr. Sakib taught you earlier, that this AVR can go up in dextrocardia if the leads are
Yes, and
misplaced and the leads are
le-
misplaced, isn't it?
yes,
Now you know there's a third condition where you can have,
left main stem disease.
yeah, and now you can see that you can have a positive AVR in
Lead
tricyclic
one.
TC
tricyclic antidepressant AVR. This is a pathognomic feature of tricyclic antidepressant
Depression.
poison.
Okay.
So if you have a positive AVR with the broad complex QRS complex, this is likely due
Left
to
um,
tricyclic
overdosing of
tricyclic.
tricyclic antidepressant.
And all the features are suggestive. QRS complexes are broad, prolonged QT, sinus tachy. Now, why I said this is important? You had this patient, and in emergency medicine, someone says the patient has taken overdose. You don't know what overdose they have taken, and ECG has been given to you. And if you miss this ECG, and if you miss this finding, because you are saying broad complex tachycardia and all those things, but you're still not able to make the diagnosis, isn't it? So if you
Yeah.
miss this diagnosis, of course you will cause the delay, isn't it, in the treatment? And
Yes.
when you cause the delay in the treatment, within few minutes, patient ECG will change. So this is, remember, pathognomic feature of tricyclic overdose is in AVR, you get the deep S wave and prominent R wave and broad QRS complex, which is never seen in any other condition. This is
Okay.
a very common MRCPQ question as well. Now, so TCA poisoning, sodium channel blocking. So basically, the mechanism is they are the sodium channel blockers, and they stop the depolarization, and you get this. Most common are the tricyclic antidepressant, and these are other medications which can also cause more or less similar prolongation. If you don't pick up that diagnosis quickly, the patient will now go into what is this now?
When
VT.
VT,
VT.
ventricle
Patient is
tachycardia.
now
Ventricle tachycardia.
absolutely, because of the delay of picking up here. Now this patient has gone into full-fledged VT.
Ventricle tachycardia.
Still, if it's ventricular tachycardia, look at the positive AVR. Look at the
Uh,
broad
upright
QRS.
deflection.
Good. And then the treatment was not that difficult. You could have just given sodium bicarbonate, and if you start giving the sodium bicarbonate infusion, intubate the patient, hyperventilate the patient, And the third ECG of the same patient, after you alkalinize the body fluids with the sodium bicarbonate, you intubate, you hyperventilate, the ECG came back to normal. This is the ECG of the same patient. Can you see that?
Yes.
You actually saved him from going into cardiac arrest. AVR, is it gone down now, isn't it? QRS complexes are getting, and what you gave, you just gave
Bicarbonate infusion.
Bicarbonate.
Yeah. So was this ECG important?
Yes.
Obviously, yes, sir.
Yeah. Good. Case 5. What do you see here? Anyone else now? I want someone new. I can't hear any female contribution. Any female? Can you please tell me what is this? Hello, can I hear? Because I can't change the screen, so I can't call you by name. Who is this?
Anam.
Okay, Dr. Anam. Can you please quickly interpret this ECG?
There's a P wave, so it is sinus and it seems to be regular.
Yeah.
There are tall
R waves.
R waves in V1, V2, but there's a normal RR progression.
So now your colleagues can help you. Others, all of you are allowed to help her. Is there any abnormality you see?
ST depression.
It's like right axis deviation is there.
So if I'm sure Dr. Saqib has taught you about, always look at P, Q, R, S. What is normally the distance between P, Q, R, S? How many small squares?
Three small squares.
Your interval is normally 0.12 to 0.2. So it's basically 3 to 5.
3 small
Yeah,
squares.
3 to 5, yeah. And if you look at this
Short
ECG,
PR interval.
so yes, the PR interval is very short, and you can see the upstroke of delta wave, isn't it? Can you see that?
Yes.
WPW.
Yeah.
So this is
Where is
So this would be a WPW syndrome.
Wolff-Parkinson-White syndrome. So what will happen? A young chap comes to you in AD. I said, I've got a palpitation. You did the ECG, and there is a chance that you can miss this finding, isn't it? There's a chance that you can
Yeah, there's a
miss
huge
this
chance.
finding. Yeah. And now this patient goes home and he dies. Someone comes next day, consultant comes, they look at the ECG and they will say, why was this missed? Second problem, even if it's in fast, the rhythm is fast, you cannot give any medication which suppresses the AV node. Like A, B, C, D are more or less contraindicated in Wolff-Parkinson-White syndrome. ABCD is adenosine, beta blockers, calcium channel blockers. All right. So you have to be very careful. I'm sure Dr. Saqib taught you about what is this delta wave, how is this generated. So on resting ECG, the PR interval was short. And very important thing I would say, if you want to pick Wolff-Parkinson-White syndrome, there's one thing is short PR interval is a pathognomic. You don't see short PR interval in any other condition. If you get an MCQ in exam, you don't say delta wave, say short PR interval, which is the most common find. Then you look at the lead V1 and V2. Look at lead. So whenever you get short PR interval delta wave, look at the lead V1 and lead V2. Can you see that? Yeah? Look at the lead V1 and V2. What do you see here?
A deep R wave.
Dominant R wave will lead V1 and V2. If you look at the normal ECG, then it will be easier for you to understand. So from first ECG, you are likely to miss the right ventricular infarct. Second ECG, you can miss the posterior infarct. Third ECG, if you don't intervene quickly, you will miss the
Patient died.
patient with the TCA poisoning, and patient will go into VT cardiac arrest. Here, if you miss the PR interval and if you miss the delta wave, then you are going to likely miss the
WPW.
WPW syndrome. And look at this, how this is the normal mechanism, isn't it? SA node to AV node, and then it goes to ventricle. This is normal PQRS, yeah? But here, SA node to AV node is actually bypassed by the accessory pathway, which causes the pre-excitation of the ventricle, and you get the delta wave. This is the mechanism. Now, so Anam, you said about the WPW syndrome. Let me pick another doctor now, because I have to stop sharing and I have to find out who else is there, because it's important. I'll pick random someone. Namra, Dr. Namra, are you with us? So if you are not responding, you will not get the certificate. Those who are not responding, it means that they just attended and they just disappear. Yeah.
Yeah.
So very well, good. So Namra is not responding.
Yes, sir.
Okay, thank you very much. So I'm going to share the screen now. This ECG. Can you see that?
No, sir.
1 minute.
No, we cannot see.
Okay, Nimra, can you see the ECG now?
Yes, sir.
Good. I want all of you to be interactive, because this is a big responsibility. When I say that, you know, the certificate you will get, which will be signed by myself and Dr. Sakib. So we want to make sure that you understand. So what do you think, Nimra, about this ECG?
The sinus is there, regular, normal rate, and
Yeah, sinus rhythm, regular, normal rate. So you know what, in emergency, what I do normally, so I ask a brief history. So ask me history. So I'll say, okay, this is a young patient or XYZ, he had a collapse. So,
Patient
okay.
age.
Yeah. So, but sometimes you don't always have the history. You know, healthcare assistant, they just do the ECG and they bring it to you. So now you see the ECG, what will worry you? So you look for any abnormal rhythm. It doesn't look like there's abnormal rhythm, isn't it? You don't.
So rhythm is regular, yes.
Yeah, there's no. The rhythm is not regular. Rhythm is regular, and you clearly don't see any acute ST changes. You clearly don't see bradyarrhythmia, tachyarrhythmias, isn't it?
Yes.
All wave
what do you-
overlapping.
But
Where?
there are tall QRS complex.
There's QRS is narrow.
Left and
Depression.
small QRS and we are overlapping.
There are tall and deep
In
QRS
V1 to
complex.
V1 to V3, these QRS complexes they're talking about.
Yes.
Yeah. So what's wrong with this QRS complexes?
Left ventricle hypertrophy.
No, left ventricle hypertrophy will be here. You are saying opposite. So
Q will
look at this V1.
Right.
P1.
RSR progression. RSR.
No, look at this
No.
QRS. Look at this QRS in lead V1. You remember I said why QRSs are small in lead V1, V2, V3. Why? Because the right ventricle is small.
Small muscles and
Small muscles. Now they are very big.
Left ventricle hypertrophy.
So
The
if you see
amplitude
here,
has increased, so it's hypertrophy.
Right ventricular hypertrophy.
Look at that.
Decreasing aortic progression. There's no aortic
Look at this.
progression.
In normal, and normal. This is your V1 RQRS. Can you see that?
Yes.
Such a
Yes.
small, isn't it? In septum.
Yeah.
In septum, there's no much muscle. So you can't have big QRS. But if you see a big QRS, it means there's a lot of muscle in septum. Is it very difficult?
Hypertrophy.
Right ventricular hypertrophy is there.
Yeah. So this is basically HOCM. Hypertrophic obstructive cardiomyopathy. And look at the QRS. Are they normal? They're very, very narrow, isn't it?
Yes.
Can you see that? They're less
Yes.
than one
should-
small square.
They should be too.
Can you see that? Can you see any difference there? Can you see any small square? Look at the normal QRS.
7 mm.
Yeah. Look at the normal QRS. You see some QRS, isn't it? There's some small square. But here, you don't see anything. So, but still the most important finding, which you should not miss is, look at the septal leads. Look at the right ventricular lead. Such a big QRS. It means there's a big muscle mass. Ask, was there a patient collapse? Was there a history of cardiac arrest in the family? This is
Hypertrophic cardiomyopathy.
Yeah. Now, again, this ECG is very commonly missed because we are just trained to pick up ST elevation MI and blocks, isn't it? Type 1, type 2 blocks. People usually pick them up. But these are the features which you normally people miss. One more thing I would say, to look at this QA in lead V6 and V5. Are they normal QAs?
No.
No.
Why?
Yeah. Look
They
at this
kind of have a
V4.
division in.
Look at the V4. Such a big Q wave, big Q wave, big Q wave. You don't normally you don't have such a big Q wave. Look at the normal ECG.
Old
Yeah?
infarct. Any old
Look
infarct?
at the normal ECG in V4. Do you see any Q wave?
No.
Is there any
No.
Q wave?
No.
No. But look at this Q wave.
Old infarct.
No. So
And
this
what
Q
is
wave,
this?
they are called dagger-like Q waves, which is deep, narrow dagger-like Q waves in the lateral and inferior lead is the pathognomic one of the feature of HOCM. Yeah, because these Q waves are actually not because of the infarct. It's because of the lot of muscles here. They are reflecting as a Q wave here. So dagger-like Q wave and prominent QRS complexes as in lead V1, V2, V3. They are the pathognomic feature of HOCM. And remember, this can be associated with Wolff-Parkinson-White syndrome. So always look at the delta wave as well. Now, how many of you knew the features of HOCM like this before attending this ECG workshop?
First time.
So,
Sir, I have a question.
So, are you with me, guys? So what I'm trying to say, that this ECG workshop is based.
How will we differentiate between a dagger-like Q wave and a normal Q wave? Like
One minute, guys. Let me finish this ECG. We'll do the question answer session as well. Now, because there's too much noise and we have to finish by maybe in half an hour. So, just remember the important points. Can you see this QRS, dagger-like Q wave? Yeah, narrow QRS complex and
Yes.
septal. This is HOCM. All right. Now, you need to ask yourself, whatever you learned today, was it taught to you in a medical school? No. Did you learn it? Did you learn it in your post graduation? No. Did you learn it in your lab? No. Did you learn during your MRCP? No.
No.
So this is a very special day in terms of that you learned something which you never learned in 10 years. All right. So
Yes.
it's a very, very big day for you in terms of ECG learning. So as much as you can make a points, as much as you can make a note, make a note. Look at this ECG. Okay, so I will pick up Sabah now. Sabah, because
yes,
what do you think about this ECG?
there are ST depressions in
First of all, what is the rate? What is the rate, rhythm, and all those things? Because
It's
No P wave.
150, 175, 60, somewhere between 60 and
Good.
50.
So heart rate is more or less 60.
I can't
No
see
P
any
wave.
P waves. So
There's no
it's
P
not a
wave.
sinus rhythm.
It's not a sinus rhythm.
It's a narrow complex.
It's a narrow complex.
And it's
Irregular.
irregular.
Yeah, the rhythm is irregular. We'll let Saba speak. And what is the obvious abnormality other than irregular AF?
So they are very fine ST depressions.
Yeah, there are ST depression. Where are the ST depression?
2, 3 AVF.
2, 3 AVF. Yeah. Where else?
And the precordial leads P1, 2, V5.
Yeah, V1, V2, V4, V5. Good, very good. So your ECG interpretation was absolutely perfect. There was no problem with that. Now, this ECG was given to you by a nurse who did an ECG on an 80-year-old female patient. What question you would like to ask? I've given you this ECG. Will you start the ACS protocol, or you want to ask something? Because it's a
BP,
different.
BP. Blood pressure.
We'll speak to Saba. Yes, blood pressure is good, but let Saba answer the question because she is on the spotlight.
So if there's any chest pain.
Good. Is there any chest pain? So there's no chest pain.
If there's any history of any cardiac history.
Well, she's known to have AF. So looking at this ECG, how many of you will start ACS protocol? Yes or no? Saba, first you.
I would probably, because these ST depressions in inferior leads
Good.
look quite ischemic to me.
Good. Very good. How many of you agree with that?
I would agree with it.
I agree.
All of you. All of you agree?
Yeah.
Now
Yeah.
imagine that you are in the busy A&E, or you are right in the psychiatry ward at the moment, or you are in the care of the elderly ward. You're sleeping at the midnight, and all of a sudden, patient says that he feels palpitation or whatever, and the nurses does the ECG. You looked at this ECG, and you say, okay, now this is the problem because there's a bit of ST elevation. I would start ACS protocol. How many of you will send drops?
I would
All
send
of
it.
you. Of
I
course,
would
you will have to do the blood test. You have to do the blood test. You will start the ACS protocol. You probably have to send the ECG to the cardiology doctor. So this will take a lot more of your effort, isn't it?
Yeah.
What the
Yes,
point
sir.
I'm trying to make is, as Saba's interpretation was perfectly fine, that there are ST depression in lead V1, V2, V3, 2, 3 AVF, V4, V5. So basically, this is the global ST segment depression, isn't it?
Yes.
Yeah.
So
Yes, sir.
global ST segment depression means there's a problem.
Pericarditis.
Left.
No,
Complete heart block.
no,
Left
no.
main stem.
Global ST segment depression means there's nothing wrong with the heart.
Placement of the leads.
There is something wrong systematically going on.
Electrolytes.
So
Chest
then you
lead placement.
no. Listen to me. So if there's a heart problem, there will be a localized ECG change, isn't it? Right? You can't have all arteries blocked. So you will have one local change, like in lateral lead, inferior lateral leads.
Pacemaker.
But you have here systemic change, isn't it? So if you have any systemic change, think about electrolyte imbalance, think about drugs, think about anemia. So you can have a patient with the anemia who can have ST segment depression throughout. But here there is something really important. If you look at this ST depression is very specific for digoxin.
Digoxin toxicity.
It's called downsloping ST depression. So you don't have ST depression downsloping in any other condition. Can you see that?
Yes,
Yeah.
yes.
This is downsloping. Normally you will see the proper ST depression. Normally you will see
It's either flat.
proper, flat ST depression, like a flat ST elevation. So this is, you will pick up that this patient is in AF, ask the nurses, is she on digoxin? Yes, She is on digoxin. Just say, patient, can you go and sleep? Patient can go to sleep again. Nothing to worry about. You don't have to start the ACS protocol. You don't have to call cardiologist, and you also go to sleep. Okay. The only thing you have to find out, is she in digoxin toxicity or not? Has she got digoxin toxicity symptoms or not? So if you can just rule out that, maximum you can say, can you please do the digoxin level if you are concerned. Okay.
Yes.
So remember, ST depression in a concave shape, known as reverse tick sign or as a Salvador-Dali sagging sign, or you just remember downsloping ST depression, which is a curve downsloping, is a classical typical feature of
Digoxin.
digoxin. And it will be throughout. So digoxin is in your blood, isn't it? It is a systemic problem.
Yeah.
Oh, that one is called UA. Mm.
All right. Happy with that?
Yes.
Yes. Sir.
Okay. So I think what I have selected, the case selection, because the problems I had in my life, and we see the A&E doctors get excited and they start the ACS pathway and all. So I thought I should bring those ECGs which are probably will not be discussed by the cardiologists. So case 8, what do you think about this? Should I pick another girl or?
Can I interrupt you for just a second? I had to ask something.
Yes, please. Yes.
Sorry. In the last case that we discussed, the one with digoxin toxicity, you said that if this patient initially had symptoms of chest pain, and these
So-
ECG findings are specific for digoxin, would we still
So
stop on
again,
this?
chest pain should not give you systemic changes. If you look at the ECG, she has the changes throughout.
Yes.
Yeah. If there's a global change, it means there's no blood vessel blocked.
Right.
Yeah.
So the chest pain would be from a non-cardiac cause then.
So you can, if there's a chest pain, and then you just want to make sure that, so you can basically send the drops and wait
Okay.
to see if
Okay.
there's, but you shouldn't be getting too excited about it.
Okay. Right.
Happy
Thank
with
you.
that?
Yeah. Thank you.
Case 8. Who wants to do this one?
Can I do it?
Yes, please.
So it's regular rhythm and regular sinus rhythm. I can see the P waves. Patient's heart rate is normal, and axis is normal, and PR interval is fine. Yeah, fairly fine. And if I can see in the anterior septal leads, I can see ST elevations in V1, 2, V3, and V4. And in the V5 and 6, I can see T wave inversions, and as well as in 1 and 2.
Biphasic T waves.
What do you think? What is wrong with this patient?
Aren't the T waves in V2 and V3 a little too high? A little
They
too
have
tall?
open cap.
So you
Biphasic T wave.
ask the history. What's wrong with the patient? I'll say nothing wrong with the patient. There's no chest pain.
Okay.
Yeah. So ask the history. So this is interpretation is absolutely fine. You see the T wave inversion in lead 1.
Yes.
Year 2, you can see the lateral leads, isn't it? So whenever you see lead 1 T wave inversion and lead AVL, or the lateral leads, lead 1 and lead V5, V6, you start thinking about, if the patient does not have any symptom, is the patient hypertensive?
Yes.
So these are hypertensive changes.
Hypertensive changes can
Yeah.
lead to ST elevations as well.
And I'm sure Dr. Saqib taught you about the criteria to diagnose the hypertension, left ventricular hypertrophy.
Yes.
Yeah.
V1
So if you
and
look
V2.
at
Depth of the R wave in V1 plus the height of the R wave in V5 or V6.
Good. And if you see the T wave inversions here, look at V5, V6, and look at the S wave, deep S wave in lead. Can you see that? Look at this S wave in lead V3. Normally, you don't see such a big S wave in lead 2, lead 3. Can you see that? Look at this normal ECG.
No.
Yeah. Look at this one, only one large square, maybe, or 1.5, isn't it?
Yep.
Yes.
But look at this. Look at this. Can you see that? Yeah. Such a big QR. So this is basically the left ventricular hypertrophy, where you see a tall R wave which is greater than 25 mm in V5 or V6, or R plus S wave greater than 35. So if you look at this R wave 5, so take this one 5, 10, 15, 20, 25, and maybe 30. 1, 2, 3, 4, 5, 6, isn't it?
Yeah.
Yes.
30.
Yes.
And if you combine with this 1, 2, 3, so this is going more than 45, isn't it? 30
Yes.
here and 3, 4 here. So easiest is you combine the amplitude of R wave, any tallest R wave with any tallest S wave, and if it's more than 35 millimeter, you call it left ventricular hypertrophy. How will you differentiate left ventricular hypertrophy from left ventricular strain? So if you
Because
only
no
have
symptoms, no
no,
symptom of chest pain.
no. If you have a left ventricular hypertrophy, you will only see the QRS complex criteria, but you will not see T wave inversions.
Okay.
If you see the T wave inversions as well, then this is left ventricular strain. So you will get this MCQs in MRCP 1 and 2 quite a lot. ECG, is the left ventricular hypertrophy, is left ventricular strain. So it's very simple. Inverted T wave in lead V5, V6, or possible ST depression plus 35, then we call it left ventricular strain. Because these ECG can excite you, isn't it? If you are in your practice, all of a sudden you will get too excited and you will start acting on it. So
what about the ST segments or are like a bit you can say elevated in the V1, V2, and V3?
You remember I said, unless this concavity is there, this is not ST elevation.
Okay.
Can you see that? This
Yeah,
concavity?
concavity is there. I can see that.
Yeah. So don't call it ST elevation.
All right.
Are you guys learning or am I too fast?
No, learning.
Learning.
Good.
Look at this one. What do you think? Or there's a very simple way to diagnose. There's a very simple way to diagnose left ventricular hypertrophy criteria. Very simple. You just look at the lead AVL. Can you see that?
Yes.
Normally, AVL should not be that big. See how many large square? 1, 2, 3, 4. 3.5, isn't it?
Yeah, almost 4 large boxes.
Normally, if you look at the AVL, look at this AVL. How small is this? Can you see that?
Yeah. Less than half a box, around half a
Yeah.
box.
But look at this AVL. So there are so many ways to do the left ventricular hypertrophy criteria. So if you look at this AVL, such a big, this is could be.
It's deep.
Yeah. Case 9. Who wants to do this one?
Can you please go back to that slide where there were criteria for LVS? Yeah, this one. Okay, so R wave in AVL, if R wave is greater than 1 millimeter, then LV. Okay, thank you.
Very simple, yeah?
Yeah.
Yes.
Are you learning new
Next,
things
please.
today?
Yes.
All right, good. Okay. Who wants to talk about this ECG? This one. Very simple, guys. Or shall I pick someone?
Can I try?
Shiraz. Anyone? You are just about to finish now.
May I?
Yes.
It's a sinus rhythm, as I can see the P waves.
Yeah.
Rhythm is regular.
Yeah.
And rate is normal.
Yeah.
There is no excess deviation.
Yeah.
PR interval is normal and QR is interval as well.
Yeah.
Normal ECG.
PR
So,
looks normal, isn't it?
so
So it's a
this is not. If you
borderline
look, yeah.
Borderline prolonged.
ST
prolonged
elevation.
PR.
So you know what? The purpose of this workshop is to at least give you some pathognomic feature so that you don't miss that. You will need to see lots. What is this? Look at this.
ST sloping early repolarization.
No, no. Look at this. PR segment.
PR segment depression.
This is PR depression, isn't it?
Concave ST.
Can you see that PR depression?
Yes, sir.
Yeah. ST
Where's
is high.
pointer?
And you can PR depression is
ST
only found.
elevation.
PR depression is only found in one condition,
Pericarditis.
which is pericarditis.
Yes, yes.
That's pericarditis. Yeah.
Yeah.
So look at that PR depression.
Yeah, it's a
PR
little bit.
depression. And you can see a bit of saddle shape ST elevation. I intentionally didn't pick up the proper ST elevation, saddle shape, because I
Pericarditis.
know this is
Pericarditis.
pericarditis. Yeah, this is pericarditis ECG. Okay. You can see the widespread ST elevation. Widespread means because the pericardium is all around, isn't it? So that's why you see widespread changes. And then PR depression. There is a reciprocal depression and PR elevation in AVR. Can you see that? This is the diagnostic criteria. Concave shape ST elevation. Concave shape ST elevation. And you see the PR depression.
PSI.
Yeah. So this will be
So for
pericarditis.
pericarditis, the ST elevation should be in all the leads, if I'm not wrong.
Yes. But
Okay.
you know what? Pericarditis, although it's a global phenomena, but sometimes not all the pericardium is inflamed. You
Okay, so
can
it's just
have
a matter of time,
like it's a pleurisy. You don't get pleurisy in all lung. You get
okay.
pleurisy in part of the lung. So you can
Okay.
have pericarditis, not globally all of them. Yes, most of the leads you can, but sometimes you may not get. That's why the pathognomic feature is PR segment depression. That's not saddle shape ST elevation.
Can we go back and look at the AVR?
Sir, is this ST elevation the concave shape that you said, okay, don't.
So this is called concave. If you look at this ST elevation,
नमाज के लिए रेडी हो गए और मास सभी का वजू करे मैं आ रहा हूँ
it's just above this QP segment, isn't it? If you see the QP segment, 1 mm is up, but this is not the ischemic. That's why they say concave shape ST elevation in pericarditis.
Is it another term used for this, the saddle type?
Saddle shape, yeah, saddle shape ST.
Can we look at the AVR? In the AVR, I can't see the PR elevation.
So you know what? These are the ECG changes in pericarditis. You don't necessarily need to get all of them in one ECG. So if you see saddle shape ST, immediately look at PR depression. Immediately look at, are there reciprocal ST depression and PR elevation in AVR? So in
that
all
means
other
the elevation of pericarditis is different from that of an STEMI.
So you will get ST segment, saddle shape ST elevation in all leads except AVR in pericarditis. This is a very common MCQ. And you get PR depression in all leads except PR elevation in AVR.
Okay.
Yeah. So AVR has got a very important role when you want to diagnose. So I can just assess anyone in the interview by just asking an ECG, and I just talk about AVR, and this will give me the understanding of the doctor. What does he think about ECG? What is the significance of AVR? If a doctor says to me, gets a positive deflection in the misplaced leads, dextrocardia, tricyclic antidepressant, and there is a significant pericarditis, there are reciprocal changes, then I will just stop myself and say, okay, this doctor has got a very good understanding of ECG. Last case. And whoever will answer this one properly, I will call them a medical doctor, a very good medical doctor. Who is, first of all, we will say who is going to participate. Who is going to take the volunteer role? What is wrong with this ECG?
Sir, AVR is upward deflected, upright AVR.
Okay, yeah, AVR, but you start seeing AVR now.
Sir, R waves में भी मसला है डेक्सो
No. You are on the wrong direction. Okay, I want emergency doctor. Who is emergency doctor here? Any emergency doctor here?
Sir, I am doing emergency.
Yes.
Who is it?
There is broad QRS.
Abdul Salam.
Last
There are
ECG.
T-wave inversions.
If someone can tell me what is this, and I'll give the next workshop free to them.
Wait, sir.
Okay, so first of all,
Sir,
there are
bundle branch block.
Right bundle branch.
Biophysic.
Come on.
Because in
Okay.
V1,
Trifascicular.
No. Okay. I'll go back to Shiraz. Shiraz, I know you've been doing A&E for a long time.
Okay. RSR phenomena.
Okay, so everyone will just keep quiet now. So we'll just see what Shiraz says because he's working in emergency medicine in UK. So yes.
Okay. So it's I can see
Case of
P
the day.
waves. So I can see P waves. So it's a sinus
Yeah.
rhythm,
Uh-huh.
regular one.
Yes.
And there is
hyperkalemia.
The 2, 3.
So this workshop will earn you next workshop free. So you will get the radiology workshop free if you give the diagnosis correct.
I think it's the right axis deviation.
What is the diagnosis? Come on, you can't miss this.
Hyperkalemia.
Sabah, your turn.
Is it trifascicular block?
Who is this?
Sabah.
Sabah. Okay, so now, very important, guys. Remember, deep S1, 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 Q3, T3 is right.
Right ventricular
With
hypertrophy.
right bundle.
Pulmonary embolism.
This,
Pulmonary
yeah,
embolism.
this is a massive pulmonary embolism. Whenever you see this ECG with the deep S wave, Q wave, T wave inversion, V3, and if you see the right bundle branch block with the T wave inversion, there's a right heart strain going on. Remember, you see that when I was saying the T wave inversion in lead V5, V6 is a left ventricular strain. If there's a T wave inversion lead V1, V2, V3, which is a significant right ventricular strain, this is a massive saddle pulmonary embolism, and you don't need any history to diagnose this. You just follow PQR. Okay, S wave, deep S wave, Q wave, T wave inversion, S1, Q3, T3 with this. And there's another very important feature for pulmonary embolism, which probably most of you guys have never gone through, and now you will never forget, which is
S1, Q3, T3.
So S1, Q3, T3, extreme right deviation. And look at this T wave inversion in V1, V2, V3. And no one has ever taught you about this, isn't it? Dominant R wave in lead V1.
Yes.
Yeah. Dominant R. If you see a dominant R wave in lead V1, just be very careful now, because normally you don't see such a big R wave in lead. It means that the right ventricle is trying its best to push, and he's getting such a big QRS complex. He's trying to give it to you, If you look at the normal QRS complex in the lead V1, if you look at the normal QRS complex in lead V1, see how small is this?
Yes.
Whenever you see a very prominent QRS complex and slight bit broad with the right bundle branch block pattern, P wave inversion, look at S1, Q3, T3, and this patient should go to
Pulmonary embolism.
this patient should go to resus
Resuscitation.
and because this patient may need a thrombolysis, so it's got a right heart valve. The urgent bedside echo should be arranged. But I think Saba's thoughts were not bad in terms of bundle branch block, but there was no PR interval prolonged, and there was no left axis deviation. So we wouldn't call trifascicular block. For trifascicular block, you need bundle branch block with the prolonged QRS and then prolonged PR interval and left axis deviation.
Yes.
So this is a massive bilateral pulmonary embolism. Never ever miss that, guys. Most important finding. I'm really, really grateful to you for joining us. Now, we already thanked Dr. Saqib, Dr. Hasham, and Dr. Salman for being with us. I hope you guys enjoyed. Now,
Yes, very much.
Yes, it was a very
so-
excellent session.
yeah.
Yes, sir. It was
Now,
excellent.
people were, you know what? I'm just finishing now. People were telling me that it's hard to keep doctors engaged whole day online. Trust me, I've done it many times, and I can still go on till night, and you will stay here, and none of you will move. So still, I can see all 35 doctors are still with us, and everyone, I hope you enjoyed. Now, I want all of you to please give us your feedback on GPEP page. If you go to GPEP Facebook page, you will find out review and recommendation section. You write your feedback, and very important thing, when you write your feedback, don't just say excellent, brilliant workshop, that's it. Because we are trying to get it accredited with the Royal Colleges, they want a very detailed feedback, which includes name of the tutors, Dr. Ash, Dr. Saqib Ghani, how it was conducted, the content, will you recommend it for other doctors or not? And you can mention about what you learned, what was good about it, what you can improve. So it should be 5-6 lines. It should not be just small feedback. Feedbacks are mandatory to get your certificate. So those who don't give feedbacks, we don't give them certificates because that's a part of our policy. If you are not on Facebook, you need to email us your feedback on GPEP, or you can inbox us, or you can write it on the event where the event is announced. The best we recommend is in the review and recommendation section of our GPEP page where you book, because all of you have booked this workshop from Facebook, isn't it?
Yes.
So all of you are on Facebook. So we want all of you to, because there are 35 doctors, by the end of tonight, all of you should give us a feedback, and as soon as you give feedback, we will send your certificates, which will carry six CPDs. Now, 6 CPDs matters a lot by sitting at home and getting it. What is the worth of these CPDs? If you give this certificate to any hospital, anywhere, which is signed by consultant cardiologists and signed by myself, definitely people will know what is the worth of this. You will get more chances to get the jobs. When you are sitting in the when you're sitting in interviews, you will be very confident. All interviews, when I had my interviews in St. Thomas's, I was given ECG. When I had my interviews in Royal London, I was given ECG. So ECGs are the part of your interviews. So you will always be given, and you will feel confident now. So I would just like to know, all of you say one small few words about this workshop. I'll start from Habib Khan. Habib Khan, were you with us, and how do you feel about this workshop?
so happy for this session because my next section is in GIM, General Medicine, as F2 in Middleborough. So I was hoping this session for me to work in general medicine. Then my last rotation is A&E. I think it's good for me to read ECG because I have some rotation on call shifts in cardiology.
Good.
So very helpful.
Thank you very much. Thank you very much. I want the same feedback to be written on your Facebook, whatever you feel positive about it. Is that all right?
Yeah.
I'll wait for you. Amjad, Amina Amjad.
Ji, Assalamu alaikum.
How do you feel about this workshop? Can you please say a few words?
Yes, it was really nice. I learned a lot from this workshop. There were many new things. Although I've done my PLAB one and I've done my house job, but there were quite a few things that I learned for the first time. So yes, it was a very nice experience for me.
Thank you very much. And we want you to please invite your friends and on our Facebook page. The more you are engaged with the GPEP, the more chances you will get with us in future. So, as soon as you invite few doctors and you are commenting, you are doing the feedback, the Facebook will give you the title of top fan. If you are the top fan of GPEP, all our workshop, irrespective, because all our workshops get fully booked within hours. So if you are in our top fan list, if you have recommended us, we will give you the seat even without, even if you don't have a, we will prioritize you. Sabah, what do you think about this?
So I worked in cardiology before, and I've graduated in 2012, but no one has taught me ECGs like this before.
All right, good. Thank you very much. So this is a very good feedback. Please don't forget to mention the same thing in the Facebook page. If you want us to improve services in Pakistan, you need to give the feedback. Hafsa Salman. I hope. Okay, Aisha Rasul. Aisha Rasul, are you here? Okay, so those who are not here, they will not get the certificate. It means that they left the session early. Ramsha Rashid. Ramsha Rashid. Okay, I can.
Can you hear me?
Yeah, Aisha Rasul.
Hello,
What do you think
can you
about? Yes, I can hear you. How do you feel
Okay.
about this workshop?
Hello, this is Ramsha. I actually enjoyed the workshop. I've been actually out of work for a while, and I wanted to join back. So I think this workshop was great for me to like strengthen my basics again, and it served a great purpose.
Good. Thank you very much for being with us, and please don't forget to mention this in our feedback so
Thank
that you
you.
can get the certificate.
Thank
Ramsha.
you.
Ramsha.
This was me talking, Ramsha.
Aisha.
I've already given my feedback.
Aisha.
Hello.
Yes.
I've learned quite a lot today. ECG has been always a difficult subject for me, but I have learned quite a lot. Thank you.
Very good. Anam.
Workshop
Anam.
because it was detailed and it had like I am a final year student, so I hope it will help me and I have become more accustomed to viewing these
Thank you. So I think I've just randomly checked few of you. Aruj, were you here? Good. Neha?
Yes, sir. I'm here. Assalamualaikum.
What do you think about this workshop?
So I already had a little knowledge related to the ECG earlier, but Dr. Sakib's continued to compare different ECGs and make us think in a broader way that I like very much. And especially the emergency session is amazing because we usually don't think about the toxicities and their ECG changes. So yes, it's very informative for me today.
Good. Shiraz, last, your words. you give the closing remarks.
Yeah, so basically when it started, I thought I knew the basic ones, but as the session passed and the day passed, I thought that I knew less and less of the ECGs, and it continuously and throughout the day built up my knowledge of the ECG. And your session was an outstanding one. I mean, every ECG had everything different in it and many findings. So I think overall the session has been amazing, and not just me, everyone has learned a lot. And I'm sure we are going to contribute a lot in the community once we come back.
Thank you very much, guys. If anyone wants to say anything, you are free. Last 5
Hello.
minutes before
Hello,
we
sir.
go. Yes, yes.
Hello, sir.
Can I speak?
Hello.
Yes, please. Yes, please. Yes,
Hello,
go ahead.
sir. Your session is very informative, very helpful, and it is very feeling good when you teach with your full dedication, passion, and it was very great time with you, and it is really amazing thing. Thank you, and
Thank you
keep
very much.
continuing all these. Very
Thank you
you.
very much. Yeah, I'll wait for your feedback. Yes. Yes.
Okay.
Dr. Ashfaq, I want to say that you are a great person, and it was a wonderful workshop, and I think you are doing a great job for every doctor.
Exactly.
And I think I love you. That's it.
Thank you. Thank you very much for your love. And we will always stay connected. Anyone wants to say anything, guys?
Thank you.
Comfortable
I
in
work
working
with you at
with
Essex.
very
I
safe.
know how dedicated and qualified you are, but for the first time I've had this session with you. It's highly recommended. And just for your post on the Facebook about Dr. Naila, so congratulations to you and Dr. Naila.
Thank you, Essen. It was really good to work with you. Essen was my
Excuse me,
colleague at
just a
my
quick
previous
question,
hospital.
please.
Hello.
Hello, just a quick question. We
Yes.
had this ECG topic, right? What can we expect from GPEP? Like, what other topics would they have for
There are,
us as in workshops?
we have designed 50 workshops. How many?
Okay.
50.
50. That includes how to manage diabetes in community, type 1, type 2, who should get insulin, who should get what. There are so many rashes, pediatrics, ENT, children's,
Internal medicines, please.
internal medicine, how to manage cardiac failure in community, how to manage hypertension in community. So
Very well.
anyone who will attend 80% of our workshops, we will give them a certificate of safe doctor in the town, which means that your name will be on our website, and we will put your location, where do you practice. So this will increase a number of patients, and you will always be given a backup support by us. Once you attend all workshops, you will be included in our members pool.
Yes, that's great initiative.
All right. So you can see my son, little one, is here now.
Yes, yeah, twin one. I think twin one. Yeah.
No, this is the little one. Yeah, good. He
Okay.
was sleeping, and now he's with
He's
me.
very cute, mashallah.
All right, good. So, last words, anyone?
Sir, I would like. Excuse me.
Yes, Hina.
Assalamualaikum. I'm Hira
Ji,
Khilkar.
walaikum salam.
I would like to say that no one can teach the ECG like you did, and Dr. Sakib did.
Exactly, wonderful.
Exactly, sir.
Thank you. Thank
It
you
was
very
very
much, guys.
beneficial.
We
are looking
want
forward
all.
for diabetes.
Yeah, you will learn a lot from us, inshallah. We are bringing a big project for all of you. We will make you compatible to all international world, all international community. If you attend our session, you will learn something which probably everyone expect an international doctor to know.
So looking forward to good session.
Sir, when you're going to
Radiology, 4 workshops will be announced in January, because December is full with ECG. In January, there will be 4 workshops for radiology, and I will include some endocrine and all those things as well.
Okay, sir, because I have.
Yeah, so those who have already paid, they are lucky, because as soon as I publish that, I know that within 1 hour.
Sir, do we have still chance for that diabetic one, DK, which you told us?
So I will say, what, as our policy is, first come first serve basis. But now we have designed that those who
Sir,
are the
in the third one, I opt for free option. So,
yeah
if it possible that I can pay, because I don't know whether I will get a chance to take that or not.
that's the PEMA, that's Pakistan Emergency Medicine Association. That's very different than GPEP. We will talk about it, but I will include you for the free sessions because I know I've got 800 requests. So
Okay,
I'm just trying to put everyone you. But
yes,
in GPEP, as soon as you give your feedbacks, you share, you invite, you become our top fan. Facebook will give you the top fan badge, and
that I
whenever
got.
and any workshop, because Neha Iftikhar is our top fan, and whenever we will announce any workshop, we will include our top fan first.
Okay, sir. Thank you so much, sir.
So, all right, I hope you guys all enjoyed.
Okay,
Thank you very
take care.
much, and
Take
wish you
care.
all the best.
Thank
Thank
you,
you.
sir.
Thank you.
Thank
Thank
you
you
very
very much.
much.
Hafiz, Allah
Thank you. Allah
Hafiz.
Hafiz.
Allah Hafiz.
I'll wait for your feedbacks. Yeah,
Okay,
Yeah, sure.
inshallah.
Okay,
in
sir.
review
Sure,
and
sir.
in review and recommendation section.
Okay.
Thank you.
Okay.
Bye bye.
Thank you.
Allah Hafiz.
Laughter, sir.